Thank you. Good evening, everyone. Thank you, Dr. Alex. He's a very good friend also. And I want to thank you first, Dr. Yu, who is my teacher and my mentor in teaching me the thyroid nodule ablation. So I will show you the two cases of thyroid and parathyroid nodule. So I will start with the cases. So first case is 67-year male that is admitted in our hospital on 22nd August 2018. Patient has history of neck swelling since 2013. The FNSC thyroid was showing the benign nodule. Patient in 2017 underwent thermal laser ablation in Italy. However, the patient said the swelling, however, persisted, is not decreasing in size, but no previous history was available and no images was there with the patient. So this is the image at the first time when he come to my department. So the ultrasound shows the large heterogeneous nodule in the right thyroid lobe. Its size is about 7.5 into 4.6 into 4.2 centimeter with presence of internal calcification and vascularity, but there was no clear cut like malignancy. We did the FNSC 2 times, so on the both times it comes out to be benign. These are the images you can show. You can see the large lesion with the heteroechoic ecotexture within it. The whole of the nodularity is like there. The whole of the left lobe is converted into a large benign nodule. This is the B mode vascularity scan, which shows there vascularity in the peripheral part, mostly in the periphery and in the some part of the upper side of the nodule. So T3, T4, TSS was in the normal range. So patient was not keen for surgery, so patient was referred to us. Usually the patient is not referred in India to us because the surgery is cheaper as compared to the microwave ablation is here. So, but this patient was specifically told he don't want surgery, so patient was referred to our department. So the hydrodissection was done to create the plate between the thyroid nodule and the adjacent structure. This is the hydrodissection. So we usually do the hydrodissection by the normal saline because we are using the microwave ablation system. Whenever we are using RFA system, then we only use the 5% dextrose because there is if we use the normal saline with the RFA, because RFA is having alternating current, so we cannot use the ionic fluid for the RFA. So we always use 5% dextrose. For the microwave, it is a continuous current. It's a microwave thermal energy. So we can use normal saline in these patients. And normal saline is isotonic to body fluids also. It reabsorbs very fastly. So mostly we use the normal saline whenever we are using the microwave system. So first we have to hydrodissect around the nodule up to the thyroid, up to the trachea, and to prevent the heating to the major vessels and the nerve. Third antenna was 16 gauge, 10 centimeter, and at the 13 watt power at interval of 10 seconds, every 10 seconds by the pedal, every 10 seconds by the moving show technique for total 10 minutes. These are the post-procedure images. I don't have any videos. These are the post-procedure images. We can see the air flags within the lesions. First, we have to create from the inferior to superior side of nodule with the moving show technique. These are the post-procedure images. I think it's stuck. I have to show. Okay. Okay. So these are the images and follow-up after 6 months. This is the pre-ablation. There was swelling. The patient was come for the cosmetic purpose. There is no other symptoms of the pressure symptoms on the vessels or anything, but there is a cosmetic purpose because the patient came to us. T3, T4, TSS was normal at that time, and after the procedure, these were the normal. And this swelling was significantly reduced after the 6-month follow-up. So come to the second case. My second case is 67-year-old male patient who came to our OPD, complained of abdominal pain since 3 months. History of the patient was received that ultrasound showed the left side multiple renal calculi. So the previous lab reports were showing the serum creatinine was increased, is likely double in normal 1.83. Calcium was increased is 10.4. Serum PTH was highly increased, like 760 picogram per ml. These are the ultrasound images which shows that right inferior parathyroid adenoma with increased vascularity. We can see this is the large parathyroid adenoma in the just inferior to the thyroid gland, and it shows increased vascularity in the peripheral part of the gland. And technetium 99 parathyroid scan shows that increased uptake into the nodule, and that increased uptake is clearly seen on these scans. So the patient was either referred for surgery or they referred to IR department. The patient but want minimal invasive technique, so patient was referred to our department. Parathyroid scan shows the adenoma, so and patient underwent microablation of the lesion under ultrasound guidance and sedations. So it's only that sedation was given, no general anesthesia was required, and we did the ablation with the microwave system, and 30 watt for the nearly 2 minutes, and by the moving shock technique only. We used the normal saline for the hydrodissection. Follow-up scan after 2 days that shows the serum creatinine mildly increased 2 milligram, calcium was nearly same, but serum PTH was drastically decreased to 208. After 6 months, the creatinine was nearly same, but PTH was severely reduced to from 700 to 74 only. So which was now in the normal range. And these are the after 6 months, these are the follow-up scan. On ultrasound, we can show there is a hyperechoic type of nodule is seen, and there is no vascularity seen within the lesion. So that means that is completely ablated with normal PTH levels and normal calcium level, and patient was just relieved of the pain because the calculus formation was very much decreased as compared to the previous. This is my team at Sir Gangaram Hospital, Delhi, India. Thank you.